Once again, thank you guys for joining. I'm Lindsay Wiley from OFMQ, the Executive Director. We're so glad you are able to join us today as we dive into today's educational session on social drivers of health, or SDOH. As we kick off today's presentation, I have a few reminders for everyone, just a few housekeeping things. First, panelists, make sure you please mute your mics when you are not actively speaking. Secondly, attendees, you guys are automatically muted for this webinar. So if you ask a question, please use the Q&A or the chat function. We will be monitoring that during the session. If we don't get to you during the session, we will answer questions after this session. We'd love to hear from you. Today's presentation will be sent out to all attendees after the session in a PDF format, so you should get that. Additionally, this session is being recorded, and the recording of this session will be available on the MyHealth Access Network website for you to revisit or to share with your colleagues. We do want to remind you about the OK Shine program. Before we dive into today's topic, I want to take a few minutes to remind everyone about the Connection Fee Assistance Program and the Sooner Select Providers Incentive Program. If you've attended these calls before, you hear this a lot, so please, I apologize. But these OK Shine programs are really an incredible opportunity for Oklahoma healthcare providers to take advantage of funding that's available now. And that funding will go away. So we really want you to take advantage. Through this OK Connection Fee Assistance Program, any organization employing a licensed healthcare providers in Oklahoma can have all one-time fees from MyHealth covered, ensuring an affordable, streamlined process to connect to the state-designated HIE. So we all know before that barriers to connection was fees, and those can be paid for through state funding that's available now. Additional related fees may also be considered, so please don't let that be a hurdle. There's an application process, and we want to help you. Just visit okshine.gov. Additionally, the Sooner Select Provider Incentive Program offers a significant financial benefits to providers. Eligible participants can see an estimated 28% increase in base fee schedule reimbursements for qualifying care and services. This includes the 18.5% base fee increase for Sooner Select providers and an additional 9.5% for Medicaid providers who are actively sending data to the HIE. So you're going to already get that 18.5%, but you get an additional 9.5% for being connected to the HIE. And that's why this is so important. There are incentive payments to help pay for any monthly fees that you incur for MyHealth services. These programs really are
Did Lindsay freeze for everyone or just me? Okay. She'll be back with us soon. We'll give her just 1 minute and we'll skip ahead.
Well, as you can see, to apply, you can complete the MyHealth application, and there's a link on your screen. And I think we might have someone drop that link in the chat as well. Okay. Guess we can go ahead and start. Jacqueline, my name is Jacqueline McDaniel. I am the Community Engagement Manager here at MyHealth Access Network. I'm so glad to be here and talk about one of my favorite things, the social drivers of health. And I'll let Katie introduce herself.
Thanks, Jackie. Katie Decker. I'm the Director of Clinical Informatics here at MyHealth. And I'm excited to join Jackie for this presentation today. Also very passionate about social drivers of health and how we can help those in our community. So I will let her get it kicked off and I'll pick up later in the presentation.
Sounds great. And if anyone has any questions, just drop your question in the chat and we'll be happy to answer those. So let's level set here. What are social drivers of health? Different spaces call it different things, social determinants of health or social needs. But pulling from HHS, Health and Human Services, social drivers are conditions or environments for which people are born live, work, play, worship, and age that affect a wide range of health. And there are, we know that there are lots of social needs, but they sort of all fit in one of these categories, which is economic stability, education access and quality, healthcare access, neighborhood and built environment, and social and community context. So as an HIE, why is social needs so important to us? MyHealth, we recognize that the need to coordinate care with so many different agencies, catering not only to a person's physical health, but also all the social needs. As you can see on the image, excuse me, healthcare accounts for only 20% of a person's overall health. So we recognize that there are other factors that may be accounted for, but that data is fragmented. So unmet social needs really negatively impacts those health outcomes. So if we think about someone with food insecurity, how it correlates to higher levels of diabetes or heart failure. And we think about housing instability that can impact someone's ability to follow through with treatment because they are more concerned with where are they going to lay their head next. And even transportation. Folks can miss appointments because they can't get there, or they aren't following up with their medication because they can't get to the pharmacy. They don't have reliable transportation to get to the pharmacy to fill that prescription. So if we step back and we look at data fragmentation by health systems, what we notice is that patients' medical information is scattered across different healthcare systems, facilities, and databases, meaning that no single provider has a complete picture of a patient's health due to a lack of visibility across all of those systems, and often resulting in fragmented care and potentially complications for patients. And so on average, a PCP may have to coordinate with at least 225 other providers in 117 other organizations. That's a lot of providers. So another way to look at this is by EHR vendor. So patient health data is divided and stored across different varying formats across health EHR systems. And so making it really difficult, again, to access and integrate a complete patient record because of a lack of sort of standardization between all of those various vendor platforms. So if we hone in really in on social needs, social data is also fragmented. So if patients' social needs like housing or food or transportation, these things are scattered across different databases and systems like the food pantry or the housing services or state agencies, really making it difficult for providers or even care coordinators or care managers to access and utilize sort of a complete picture of a person's social needs for any kind of comprehensive care planning or intervention. So we wanted to start off with a story. So we think about Sally Sue. She's a mother of 3. She loses her job, right? And as a result, she struggles to pay for rent, utilities. She goes to the doctor for an asthma attack. She receives her healthcare, standard healthcare and an inhaler prescription for her asthma. But the reality is Sally does not have enough money to do all of the things. She doesn't have money to pay for her prescription and for food and utilities and rent. And so to really provide the best for her family, she decides not to fill her prescription. And as a result, she suffers an asthma attack and goes to the ER. So to help MyHealth really continue to fulfill our mission of supporting providers so they can better monitor and improve patient care, reduce healthcare costs and improve quality of care, we applied to and were awarded funding from CMS, Center for Medicaid and Medicare, through their innovation department to determine if identifying and addressing health-related social needs impacts healthcare costs and healthcare utilization. So we served as a bridge organization, really being sort of standing in the gap of connecting community service organizations and healthcare providers. Our project really focused in on the five core needs, understanding that there are lots of social needs, but this project really focused in on housing and stability, food, transportation, utilities, and interpersonal and domestic violence. One of the things that we did do when we started this project is that we sort of worked with a few pilot projects. And what we learned is that in-person screening took about 12 to 15 minutes per patient. And so then when you look at tailoring referrals for those patients based on their screening, it took another 5 to 10 minutes per patient. And then you account for EHR documentation, that's a lot of time. And so in-person screening can be very costly and expensive. And providers that we were working with really were not willing to take on that additional burden, which led us to sort of a novel solution is by leveraging our HIE and technology infrastructure, we were able to send screenings to a patient's mobile device. And then that screening is completed and needs are identified in close to real time. And a resource is sent to them. So what that looks like, so if you were a patient, that you would receive a text that looks very similar to this on your cell phone. And once, as mentioned, you complete the screening, these are sort of the screenshots of what that looks like. The questions obviously are all specific, as I had mentioned, to the 5 core social needs. And once that's completed, this last screenshot of referrals lists 3 resources specifically for food. And as you can see, it's clickable. It includes an address, a phone number, as well as a website that really sort of then empowers that patient to reach out to that resource and referral when and where they need it. So if we go back to Sally Sue and kind of look at her situation, when she gets to the doctor's office, she checks in, she completes her social needs screening for food, rent, and utilities, and she receives the 3 resources for each of those. She receives a prescription for an inhaler, but in addition to that, she is now able, because she received those resources, goes to Catholic Charities to get all of those 3 needs addressed. Because she's able to do that, she's now able to fill her prescription for the inhaler. And then clinic staff have the ability to receive a report of Sally's needs, which then allows, based on the screening, clinic staff can refer Sally to a case manager. So just wanted to also share just a quick, so because this was when we started our social needs screening, it was part of a federal project through AHC, and some of the evaluation included, well, there was some evaluation, but what you see right now is that Oklahoma was one of the states that received the funding for the AHC model. And there were a few others that were county specific or partial counties. Katie, were you gonna, sorry, I'm just keep going.
You're great. I was going to pick up at go over the screening metrics when we get to that.
Okay. All right. Just want to double check. So what we learned from the overall AHC model, what CMS findings were, is that over 1 million Medicare and Medicaid beneficiaries were screened for social needs. And so more than a third of those screened beneficiaries had 1 or more of the 5 core social needs, which was the housing, transportation, utilities, domestic violence, and transportation. And so obviously housing was really the greatest, food insecurity was the greatest need. And through December 2021, all of the what they call bridge organizations that included MyHealth screened over 1 million unique Medicare and Medicaid beneficiaries. So CMS evaluation shows the effectiveness of the model. They found a reduction in the sort of 4 key measures, which were total expenditure, inpatient admissions, readmissions, and ED visits. So some of the greatest value that has come out of our work over the last few years is that we now can sort of quality how to get the needs of Oklahomans, and we can identify individuals who are most at risk we can get that information to their provider. We know that also identifying and addressing health-related social needs can be one of the first steps to addressing health disparities or inequities. So really just quickly, as I'd mentioned previously, we did a time motion study of the sort of manual screening and referral process. And what we found that MyHealth's mobile screening saved sort of over 253,000 hours of staff time and a cost savings of $4.4 million. So, so what we learned, obviously, is the issue is that social needs screening is rare and widely varies based on methods and the types of screenings folks are using. Referrals are not often tailored to an individual's needs. Our screening really looks at using our technology infrastructure, the HIE. We're able to know where that patient is located based on their zip code, and so we're able to provide them with resources based on that zip code. Data is not standardized or shared, so it makes it's a challenge to really understand what community needs are or patients' needs are. Our solution is to provide a standardized social needs screening and referral really at every site of care or provider. We can evaluate and plan for additional needs based on that data. And as a result, we know that can improve the health of individuals and populations and the communities that we serve. So another look, just kind of what the process looks like. Today, we offer providers a couple of different screening options. The first is sort of our traditional, what we did with during the AHC project, which is the encounter-based screening or site-based, provider-based screening. It starts with the patient checking in, and an HL7 or ADT message is sent from their EMR. And MyHealth generates and sends a text message with a unique link to that screening. That link is then received via text message on the patient's cell phone. They complete that screening on a HIPAA-compliant web-based platform. Our system processes those results, and then we assess, was there a social need reported? If not, then that is really the end of that process. If yes, they answered yes to any of those questions, our system generates and sends them a custom community referral summary via text message back to that same text message. And they receive that link on their cell phone with that list of resources and are able to utilize those resources when and where they need them. And then in addition, if a provider is interested, they have the ability to receive a report of all the patients that receive that screening. The second option here is roster-based screening. And really the only difference here is instead of identifying sort of the location for deploying screenings, the participant gets to identify the patients. So this is deployed at various intervals specific to that provider or that participants, the days or time of day that they would like for patients to receive the roster. So the screening. So the participant will generate or send us a roster of their patients that they're interested in being screened. And the process through that is exactly the same as I had previously mentioned. We talked about, as mentioned, participants can choose to elect a report to be sent to the clinic or the hospital system. We offer two reports. One is the participant report that includes the patient demographics, date it was sent, status of the completion of the survey and the responses. The second is the text log report, which includes patient demographics, the text message, like the status, did they opt out of the messages? There is, for participants that choose this, there is an additional charge to see these results because it requires some additional integration, development, and setup on our end. Katie?
Thanks, Jackie. All right, and so I'm going to go over, we have a few slides just sharing some program metrics over the years. And if you are also happen to be in SDOH committee, then these will look very familiar to you. But if not, oh, and Jackie, will you click one more time? I think, yeah, there we go. Thank you. So something that we hit a milestone that we hit, I think, within the last 2 months, that we're very excited about is you can see that we've now offered over 5 million screenings since beginning in 2018. So very excited about that. And as you can see, about 20% of those screenings that are offered, or 80% of the screenings that are offered, so the texts go out, about 84% of them are actually delivered, right phone number, actually delivered. So that's a high rate. And then about 21% of those that are delivered get responded to. And then of those that have a response, we capture an overall need rate of about 20%. And as Jackie shared earlier, you can see the second bar down that food need rate is one of the highest needs reported, and that is has been pretty consistent over the years. Next slide. And this is just showing kind of we do a year-over-year comparison. So this is 23 to 24. There were some, you'll notice in 2024, there were a couple of months where we had lower rates than typical, and that was due to one of the organizations that had a system outage. So we can anticipate these numbers to continue growing over the next year. Next slide, thank you. All right, and this is just a breakdown of those that responded with a need. This is a breakdown of the insurance that was reported. So probably not surprisingly, the underinsured, so those with no insurance or with Medicaid coverage, are reporting the highest needs. Next slide. And then this one was interesting to me when I first started doing this presentation. So this is screening needs by age. And so the 19 to 29-year-old range is for the most part higher than the other age ranges. So you can see a little bit of variance, but so something, just to kind of food for thought as you're thinking about the populations of need in your practices or organizations. There may also be the component of a higher response rate from that population, since the survey is coming through text message. All right, next slide. And then this is a little more detailed, but just kind of showing the makeup right now. The surveys or screenings that we're sending out are primarily related to health system organization participants with some payer partnerships. And we're very excited that we're working with some of the payer entities really closely and to roll out some additional screenings. So we should see that orange portion of the bar jump up quite a bit in 2025. All right, and then SDOH enhancements. So for those of you that use the provider portal, you're familiar with kind of how if there's a screening and an encounter with the provider, it's kind of integrated into the documents or the encounter section of the EHR. Right now we don't, or of the portal. Right now in the portal we don't have a place for the survey responses that we send out. And that is something that we would like to have integrated. And so we're working with our portal vendor and looking at some different options. This is something that we've talked about at the different governance committees within our organization to gain feedback and see what would be most valuable to the end user. And so far what we're hearing is having kind of a separate section. Jack, if you can flip to the next slide. Having kind of a separate section in the portal designated to the results of these screening surveys, kind of categorized by domain of need, and where you can see over time how those needs may have changed. So it's kind of a unique use case for adding something to the portal, but we're actively working on it and excited to hopefully get there in the next few months or a year. So. All right, what questions? or OFMQ team, if you have any additional comments, if we forgot anything, we'd love your feedback too. Checking the chat. Am I missing anything, Jackie? All right. Well, if there isn't anything further, I think Jackie is our contact information included in the in the presentation. Perfect. So
Yeah.
please, any questions or concerns you think of later, please reach out. As Jackie said, this is an area we're very excited about continuing to develop and work with our partners. So we'd love to hear from you.
All right. Thank you everyone for joining today. If you do have additional questions like Katie and Jacqueline brought up, feel free to send us emails. You have our contact information, and you will shortly be getting an email from MyHealth with a PDF of today's presentation, as well as an opportunity for you to provide feedback on today's session and information on upcoming sessions. For example, the next session on February 26th, which is on MyHealth's Provider Portal Trusted Host Training, hosted by Hannah Odding, MyHealth's Training and Support Specialist. For more information on HI office hours, feel free to visit myhealth.com or myhealthaccess.net, I apologize, /HIE office hours. Again, thank you for your time today and your participation. If you have any further questions, don't feel free to reach out. Enjoy the rest of your Wednesday.
Thank you.
Thanks.